Amazing.
Love that.
Great.
Love that sound.
Okay.
Okay, Assalamu alaikum, everybody. My name is Ibrahim Alodhaibi. I'm a third-year medical student.
My name is Eman. I'm a fifth-year medical student.
And today we're doing psychiatry practice questions.
I just finished neuro, and Ibrahim enjoyed it a lot last year. So hopefully we're going to be well equipped to help you guys today. If you guys have any questions, please just stop us at any time. Ask your question in the chat. I have it open on my laptop so we can see everything you guys say or want to ask or anything. And if we can't get to it in the moment, we'll get to it after, okay?
Yeah, and feel free to interrupt us whenever. Now, we got about 2 or so questions from each lecture of psychiatry that you guys took. And then under each question, we wrote what lecture that's from. Also under this slide, there are just a bunch of points that I wrote, just random general psychiatry information that I think is important to remember. So that's like something that you can read just before going into the exam. So we'll share those slides with you. Now, in order for the session to be fun, we want you guys to interact and engage with us. Without further ado, let's begin. Here's our first question.
All right.
Do you want to read it?
Sure, I don't mind. Okay. Does anybody else want to read it out loud, or would you guys prefer that we read the questions? Anything is fine. I like to ask this every time, and every time it's the same answer. I'll go ahead and read it. Okay. Okay. So, a 59-year-old man comes to the physician because of unexplained weight loss over the past 8 months. During the examination, he tells the physician that he has been having marital issues with his wife. He filed for bankruptcy 2 months ago for a business he had owned with his brother until his brother died of skin cancer a year ago. He has tried to hide his financial issues from his wife and explains that he is feeling increasingly desperate and no longer sees the light at the end of the tunnel. He worries about finances and what would happen if he developed cancer like his brother, and then he cannot fall asleep. In the morning, he feels tired and finds it hard to start the day. The patient says the symptoms began a few months after his brother's death, and then everything started to fall apart. I can't concentrate. My wife will probably leave me soon. And now I have lost the business. Which of the following should be the physician's next step?
So
is it A, evaluate for depression, B, send for imaging to rule out malignancy, C, assess for suicide risk, D, advise to begin family therapy, or E, collect urine sample? So in the chat, majority of you guys are saying C.
Yay.
Literally all of you. So good job.
Good job.
Why don't you want to evaluate for depression?
Also, can you guys send your answers privately to Eman so that you all don't see each other's answers?
Yeah, I mean, try to. Okay, so Noor was saying assessing suicide and asking about the drugs are the main first questions to be asked. Good.
Perfect. So yeah, especially, I mean, looking at the case right here, this guy is going through a depressing time in his life, right? He's having marital issues, his brother died, his company is falling apart. But the main concerning thing that should be jumping out to you is that he doesn't see the light at the end of the tunnel. And so this patient is at risk of suicide. And in the approach to psychiatric lectures, one of the first things that you want to, or psychiatric interviews, one of the first things that you want to rule out is suicidal ideation in a patient, because you want to make sure that that doesn't happen.
Perfect.
Is everyone clear as to why this is C?
Clear.
Good. Guys, this question is like, I'm 99% sure this is going to come on your exam. Like
it also comes in the future.
Yeah.
In 5th year, it's incredibly important. You always want to do in SIGI caps. You go for the last S and you can evaluate for depression. The thing is, evaluating for depression is also quite clinical. You can tell just from like the brief history that you take from a patient, this is most likely depression, but wait, let me see. Do they want to harm themselves? So that's the first thing that you want to rule out. Okay.
All right. Question 2. I'll read it. Ibrahim is a psychiatrist who gets annoyed with his sassy patient. Later on, when he thought about it, he realized the patient reminded him of his younger sister. Which defense mechanism is Ibrahim demonstrating? Okay, we're getting some answers.
Mm-hmm.
Mm-hmm.
Okay, so we've gotten B and we've gotten E. So let's talk about it very briefly. Okay, we even got an A. So let's see between these. Okay, so firstly, B, you guys are showing countertransference. Majority of you said that, but let's see for the other answers that you guys mentioned. So E, reaction formation, and A, transference.
All right. Do you want me to explain what? I can
Yeah, you
explain
can go
what those
ahead.
are.
Yeah.
So the answer to this question is B, it's countertransference. And basically, these are things that happen in transference and countertransference are things that happen between a therapist or a psychiatrist and a patient.
Mhm.
So this is a good picture demonstrating kind of what's going on. In transference, what's happening is that the patient is projecting their feelings and their emotions onto the therapist. So commonly, a lot of patients will look at their therapist as a father figure or as a mother figure or as a sibling. So when you're doing transference, you're connecting the therapist to a person, a past person in your life. That is a very normal thing that happens a lot. Countertransference, which is what's happening in this case, is when the psychiatrist or the therapist does that, but to the patient. All right. So in this situation, me, the psychiatrist, I'm getting annoyed with the sassy patient because it's reminding me of my sister. All right. So here, that's what countertransference is. Do we get the difference between these two things? Both of them, by the way, are things that happen very naturally.
Mhm. Great.
Yeah, it's clear.
So when do you do it to the psychiatrist? It's transference, and if it's to the patient, it's
Yes,
counter.
exactly.
Yes.
So just to recap, when the patient is doing it to the psychiatrist, this is transference. When the psychiatrist is doing it to the patient, this is countertransference. Now for reaction formation, for the person that answered E, reaction formation is when you take an emotion that you have towards a certain topic and you sort of project it with the complete opposite. So a common thing is, I think this is the example you guys got in your psychiatry lecture, is like, oh, the boss is in love with his secretary, and so his reaction formation or his defense mechanism for that is to say that, or to hate her and to outlash at her. I think that's the word.
Mhm.
So that's what a reaction formation here, and that's not what's happening in this case. In this case, I am projecting my feelings onto the patient.
Mhm.
Do we get that?
So basically, reaction formation, an example is like a stepfather treats a child he resents, so like hates, with excessive nurturing and overprotection. So you're compensating with like the opposite reaction or feeling that you're trying to like create towards that person or object.
Yes, absolutely. Reaction formation can be turning trauma into a joke.
I wouldn't say so, honestly.
That's more humor,
Yeah,
which is a mature defense mechanism. You'll take that in VHS.
it is a different one. Yeah.
Now here, so in case they had mentioned him missing her, we choose E. Reaction formation is going to be a more obvious case where it's like, they'll tell you that this person secretly loves this person, and then the case is going to be them outwardly hating on them. All right, so it's going to be a very obvious case of like two very different opposite emotions.
So majority of the time in reaction formation, this is what I've seen from step 1 questions and from previous questions when I was practicing in second year as well, and currently. When the answer is reaction formation, majority of the time, the actual like vignette or question will be like a mother or a father or a stepmother or a stepfather basically acting in a very opposite way towards how they feel about the child. Typically a step parent, so like a stepmother who doesn't like the child, so she's over nurturing. Same thing with a stepfather, doesn't like the child, but they're over nurturing. Typically, that's what you'll see in the clinical vignette when the answer is reaction formation.
Okay, and can you give an example of countertransference? So this question is an example of countertransference. So countertransference is, again, when C, identification with aggressor. How can we give an example of that? Let me finish giving an example of countertransference, what you think. So an example of countertransference would be, for example, if I'm a psychiatrist and I have a patient that is reminding me, let's say, a lot of my wife, right? I am subconsciously going to have more positive emotions towards this patient because this patient is reminding me of somebody I love. Is that clear? So like if I have a patient and she's reminding me of my wife, I might empathize with her more. I might be more moved by her stories. Are we clear with what countertransference is? And then I think identification with aggression is kind of like Stockholm syndrome.
A little, it's a lot more extreme than this. It's basically for people who have been in very like traumatic situations, like political traumatic situations or extreme situations such as concentration cramps,
Yeah.
concentration camps. It's a specific type of defense mechanism. And yeah.
Could be someone, could be someone I hate. Yeah, countertransference could be someone you hate.
Yeah.
So countertransference could be someone you love, could be someone you hate. So for example, in this case, I don't actually hate my sister, but like, there was a negative attribute in the patient, which is being sassy.
Mhm.
And this reminded me of my sister who is sassy. So that is countertransference. I am envisioning the patient as she is my sister.
Exactly. So over here in the vignette, they're saying literally the psychiatrist realized the patient reminded him of his younger sister. That's why it's countertransference. But if the vignette were to say the psychiatrist, because of like horrible feelings, ended up becoming very nurturing, that would be reaction formation, for example. So it's the way it's basically like kind of described and worded in the question.
Is countertransference and transference just projection, but between psych and patient? Yeah.
Between physician and patient.
Yeah.
Yeah. Not just a psychiatrist, but any physician and patient. So transference from patient to physician, countertransference from physician to patient.
To patient.
That's literally it. All right. Anything else for this?
Fun fact about this question, we got 2 questions about countertransference on our final. Literally the same case twice.
It's pretty important.
And it messed all of us up because we put one transference for one of them and countertransference for the other. So make sure you're able to distinguish between the two because you can't get the same thing twice. Okay, I'm gonna move on.
Sure. Next question. Okay. So.
Sorry.
A 45-year-old man is brought to the physician by his wife because of difficulty sleeping and poor appetite for the past 4 weeks. During this period, he has also had persistent sadness and difficulty concentrating on tasks, because of which he has been reprimanded at work for poor performance. Over the past 3 years, he has often had such phases with a maximum symptom-free gap of 1 month between each of them. His behavior is causing a strain in his relationships with his wife and his children. His mother died 4 months ago from breast cancer. Physical examination shows no abnormalities. Mental status exam shows a depressed mood and constricted affect. Which of the following is the most likely diagnosis in this patient? A, persistent depressive disorder or dysthymia. B, adjustment disorder with depressed mood. C, bipolar I. D, major depressive disorder. Or E, pathological grief.
I'm gonna go back to the case because I want you guys to look through the findings in this case.
What pops out or like stands out to you in this vignette that's important?
But now they can't see the answers. Look at the answers. Okay, persistent sadness.
Okay. You're getting different answers. So we got persistent sadness. We've got adjustment disorder with depressed mood.
Okay.
We've got another persistent depressive disorder. Who else?
This is a harder question, by the way, for psych.
So a lot of you are in between A and B.
Let's get one more answer and then start discussing. All right.
Okay.
Can you go back? Yes.
Sure.
Okay.
All right.
So can someone tell me why they think the answer is B? And then I want someone to tell me why they think the answer is A, because those are the 2 answers that we've gotten.
Yeah. And you don't have to direct message it. You can put it.
Yeah, you can just type it in the chat or you can unmute yourself and explain.
Definitely.
Don't be shy. They might be typing it here as well. Some people are direct messaging me that I can't see, so I'll have to leave the chat open. Okay. No one's gonna explain it. I'm gonna explain it.
Okay.
All right. Should I show them the answer or should we explain it first?
First, explain the vignette, I think.
Okay, so
Point out the
let's
important things that
let's
lead to the answer.
oops.
Oh,
Guys,
always
like you didn't see that. Okay, so let's go through the vignette. So we have a 45-year-old man who is brought to the physician by his wife because he has difficulty sleeping. So right away, what we need to do is we need to go through SIGI-CAPS. All right, this is a case about depression. What kind of depression? We're not sure yet, but it's a case about depression. So we have difficulty sleeping. That's one of SIGI-CAPS. We have poor appetite. Okay, we have persistent sadness and difficulty concentrating on tasks. All right, which is giving him poor performance at work. Now this is lasting for 3 years. Now, what's super important in psychiatry is that you always need to look at how long each thing is going on. And I think we have a table later on that shows the different diagnosis for different timelines, because how long something goes on changes the name of what the diagnosis is.
mm-hmm.
All right.
And how you treat it.
And how you treat it. Yeah. His mother died 4 months ago from breast cancer. That's fine. He's still grieving that. That's normal. There's nothing crazy there. No abnormalities. He has a depressed mood. All right. So we hit maybe 3 or 4 of SIGI-CAPS in this question, not 5 or more than that. And what this leads us to is an answer of persistent depressive disorder. So what happens in persistent depressive disorder is you're essentially not really hitting all the criteria for major depressive disorder. And it's good that none of you guys answered major depressive disorder for this question. And the other thing with persistent depressive disorder is that it's going on for a very, very, very long time, like more than 2 years usually. And it's usually periods of, like we said here, he has phases of it with a month gap between each one. Now, the reason the answer is not B for this is because adjustment disorder is something very common that a lot of us actually go through in our lifetimes. And adjustment disorder is something that happens when you're put in a new environment or in a new situation and you're adjusting to it. And adjustment disorder usually is never going to last for more than 6 months. Once adjustment disorder is going on for more than 6 months, it's going to be called something new. So because this patient is having this for 3 years, we can no longer call it adjustment disorder. This patient is having dysthymia or persistent depressive disorder.
Mm-hmm.
Is that clear for everybody? Can you put the chat?
Mm-hmm.
Clear. Yay.
Nice.
Does the adjustment disorder become major depressive disorder after 6 months, or is it something else? So adjustment disorder doesn't automatically become major depressive disorder. Again, you have to take into consideration the SIGI-CAPS. So I believe for major depressive disorder, you have to hit greater than or equal to 5 of the letters in SIGI-CAP for it to be considered major depressive disorder. And it has to be for more than 2 weeks or something like that. Adjustment disorder is just if they had something kind of big going on in their life, and then they are adjusting to that. That's just a sort of normal reaction with what's going on.
So adjustment disorder is within 3 months. Okay, for this patient, 4 months ago, his mother died.
Yeah,
right?
4 months
ago. When you reach 6 months, it's not necessarily MDD. You just have to figure out, okay, this is still persisting. What is the problem? It could be major depressive disorder. It could be generalized anxiety disorder. There is a plethora of ways in which they can actually present. So you just have to check out what the problem is. It's not necessarily depression. It could be something else. Does that make sense?
I'm going to say something else. Doctors. Also, one thing that helps me remember adjustment disorder a lot is think about it as when you first entered first year. A lot of us, it's a huge adjustment. It's a huge adjustment for us. A lot of us probably went through a phase where we were not feeling ourselves. We were not feeling very great. We were probably pretty sad. That's a typical example of adjustment disorder. That's when you're going through a change in your life that is going to have an effect on your mood. Okay, with that, I'm going on. I hate that noise. I'm going on to the next question. Eman.
All right. Guys, for when you want to ask a question or share an answer, if you want to direct message it to me, not Ibrahim, because I have the chat open on my laptop for the both of us. Okay.
Please don't mind me asking, but what is CG? Oh,
Sticky
sticky
caps?
caps. We're gonna get into sticky caps in
It's a depression criteria. We'll show it to you in a bit, like Ibrahim mentioned.
yeah. We're
Okay.
gonna get into it, I think, in the next slide.
Okay. So, do you want me to read it?
Yeah.
Okay. A woman presents with inability to stay asleep, low mood, loss of interest, increased appetite, and constant fatigue. She stated that her symptoms worsened after birth of her now 4-year-old son, Ibrahim. Which of the following is the correct diagnosis? A, postpartum depression, B, postpartum blues, C, cyclothymia, D, bipolar II, E, MDD. So, some people are saying postpartum blues, one postpartum depression, and one major depressive disorder. Okay, a lot of people are saying
Okay.
MDD.
So we got some postpartum depression, some postpartum blues, and we're also getting MDD.
Mhm.
Are you guys ready for the big reveal?
Okay, so before we go into that, say the things.
Yeah, tell us what.
Why is it giving you MDD? Blues because no medications. Okay. E because inability to stay asleep. So okay, let's go. Let's start sticky caps before we show it to you, I guess. S, sleep. So inability to stay asleep. I, loss of interest. Okay. G, guilt. That's not mentioned here. E, energy, constant fatigue. Okay. Siggy. Concentration. Sure.
Okay.
A, appetite lost.
Yeah.
P, psychomotor retardation. It's not mentioned here. But that's 4 so far.
Yeah.
P, low mood is 1.
Yeah. Anyways,
but you get the
we
point.
hit 5. We hit 5 for sticky caps. Okay, they listed it in. We listed it right back to back. Wait, what we have here is a sticky caps case. We have a major depressive case here. Now, this woman has major depression. The reason she has major depression is because she is hitting all the criteria for sticky caps. The birth of her 4-year-old son, Ibrahim, is kind of irrelevant to this, but you will get, you are going to get scenarios like this in real life, which is going to make you think, oh, postpartum depression, postpartum blues. Why is it not these things? Postpartum blues is a very normal thing that happens after giving birth to a child. I'm speaking from experience, clearly. That was such a stupid joke. But postpartum blues is like within like the first 2 weeks or so of having a kid, there's a lot of hormonal changes in the woman giving birth, and that's going to lead to sadness. Now, that usually goes away, and it's not all the symptoms of depression. It's not all of sticky caps. Postpartum depression is when that's extending beyond that normal range. And we're going to get into the postpartum stuff a little bit later in this lecture. But because these things are persisting, someone mentioned before the birth of the child and even after the birth of the child, it kind of has nothing to do with postpartum. Cyclothymia is like, I think, minor depression that's coming and going. So that's not relevant here. Bipolar disorder or bipolar II, we're not getting any mania symptoms here, so we can't say that. And that brings us to major depressive disorder. Now, what have we been talking about this whole time? Siggy caps, the holy grail of diagnosing depression. Anytime you are approaching a psychiatry case or a psychiatry vigilante with what you might think is a depression, you need to write this down and you need to start going through the question and underlining which of these you're hitting. Okay, you need to see, are they having a loss of sleep, interest, guilt, energy, concentration? Are they having any suicidal ideation? Because once you hit around 5 of these, you're going for major depressive disorder. All right, and we did that here. In this question, we have inability, stay asleep, low mood, loss of interest, increased appetite, constant fatigue. All of these are symptoms of depression. All of these are matching. So this person has major depression.
Make sense? Clear, yes.
Yay. Yay.
Just check yours for a second in case people are still
true.
texting you. Yeah.
No, these are the other chats. A. Okay. Did everyone get why it's
what does interest mean? Just loss of interest.
Yeah, and like their day-to-day enjoyments, like hobbies, what
Yeah.
they like to do.
Oh, I used to love to cook. Now I don't want to do it anymore. I used to go play football with my friends. Now I don't want to anymore. Like anhedonia.
I don't remember what that word
Me
means.
neither.
Wait, I have to Google it.
We're sorry. I think so though. I think that's the fancy way of saying loss of interest, if I'm not wrong. I got it. It's okay.
Someone replied.
Anhedonia means loss of interest. Thank you, Ghaid. Thank you so much. Yes, like anhedonia.
Yeah. So yeah, like anhedonia.
Thank you. No problem. Okay.
Are we all clear with Siggy caps? Siggy caps is important. Like, memorize this mnemonic because this is diagnostic. You use this to diagnose depression.
This is very important. All right.
Okay, I'm moving on.
Okay. Do you want to read it or do you want me to read it?
Did you read the last one?
I did.
Okay.
Okay.
A 32-year-old woman is brought into the emergency room by her husband after claiming she saw wild Pokemon in the street. I forgot I wrote this. Upon further history taking, the patient that stated that she has been sleeping poorly, hasn't been very interested in her usual activities. Her husband also stated that she's been eating less, is not very interested in the conversation, and shares that he's worried about her well-being. What would be your management of choice?
Okay. So what stands out to you guys in this vignette? Text, yallah, I'm waiting.
I think someone messaged me.
B plus what was the Pokemon?
I mean, I'll reveal it after I tell you guys the answer.
She saw Pokemon.
Okay, this one threw them.
CBT
This one
only.
threw them in for a loop. Uh-oh.
Some are saying CBT plus SSRIs. A lot of you guys are in between B and C. Okay. Anyone else?
Maybe B.
Maybe B. Okay. Now she saw wild Pokemon in the street. Okay, so Ghaid is saying the Pokemon could be a hallucination.
Or a delusion.
Or, yeah.
That was a hint, you guys.
Yeah, so does that change what you think the answer might be, or do you want to keep it the same?
Okay.
Okay, so
We're
people are still
sticking
voting
with
for
B.
B. Okay,
You want to explain this one?
you can go ahead because you put the Pokemon.
Okay. So actually the answer to this question is D. This patient is having features of depression. Okay, we see Siggy caps here. We see, again, sleeping poorly, not interested, not eating, not concentrated, well-being. Like, she's got Siggy cap, she's got depression. But what should stand out to you guys here, and maybe this was a little confusing because I wrote it, but is that she saw a wild Pokemon in the street, which is not something that can happen in real life. What this was meant to stand out to you guys is, and I apologize, maybe it wasn't clear, is that this is the feature of psychosis. This woman is seeing things that are not fixed in reality, okay? As much as I would love to see Pokemon in real life, it's not happening. This woman is having depression with features of psychosis. Now, when you have a patient that is having both of these things, the first line and the best thing to do with them is to give them electroconvulsive therapy. And, oops, here is the slide where that is said.
Psychotic features. Basically, when you are screening for any type of mood disorder, including depression, you will always follow up with firstly signs of psychosis and then like mania, right? But most importantly, signs of psychosis, because this changes the trajectory of your management. Okay, it depends. It completely changes what medications you give and what you do in your clinic. Is it just going to be CBT, cognitive behavioral therapy, or are you also going to do electroconvulsive therapy? So over here, like Ibrahim mentioned, there's obvious Siggy caps traits, but the hallucination of seeing wild Pokemon in the street, normally depressed people don't see that. That is a psychotic feature. So you will now kind of reassess your answer. Does that make sense? Can't this be schizophrenia? So schizophrenia, okay, I understand why you're asking that. Can you go back to the question?
Yeah.
Okay. So schizophrenia is a diagnosis based off of other DSM-5 criteria. You don't use Siggy caps in that. And number two, it is also a, what do you call it? It is a diagnosis made on symptom duration, okay? We're going to get to it a little bit later. But no, it's not necessarily going to be just schizophrenia, but this can just be a, you can have elements of psychosis without having schizophrenia. Like it's not diagnosed schizophrenia. There's no, from what I remember right now, yeah, there's no duration mentioned. So we can't say it's schizophrenia.
Is schizophrenia only auditory
No,
hallucinations?
not only. It is mainly
auditory
That's like usually the first type of hallucination you will experience. It's the most common, but it's not the only one. Does that make sense, guys?
Guys, did we get it? I feel bad.
Don't feel
I
bad.
threw you all off.
No, it's okay.
The reason I brought this question is because we got this in our exam. It wasn't the same scenario, but we got this in our final. We got depression features with psychosis, and it was electroconvulsion therapy. And I remember thinking, wow, why would we be asked about this? Because there's so many other things to ask about, but it's important.
You do see it in real life as well, like in the clinic with actual patients. So more often than you see like schizophrenia. So
yeah, psychosis, again, schizophrenia is a duration thing. So psychosis, they're gonna present pretty much right away if they're having an episode of psychosis. All right,
next question.
What's the difference?
Visual hallucination in this case, though, isn't a Pokemon hallucination? Is it because it's something that's impossible to find IRL?
Yeah,
it is a visual hallucination.
it is a visual hallucination.
But just because she's having a hallucination doesn't mean it's full-blown schizophrenia. Again, schizophrenia is a whole disease that you have to diagnose, and it has to be very carefully diagnosed because it has a bunch of treatment plans. This person was brought in because she had a hallucination among other symptoms of depression. Okay. And again, schizophrenia is a diagnosis of symptom duration. So how long they're experiencing certain symptoms.
Also, just one word of advice for you guys in terms of psychiatry. It gets confusing because everything overlaps, honestly. So even if you're seeing a lot of symptoms of one thing in a vignette, don't eliminate other things, because a lot of these, especially with hallucinations and delusions and features of depression, all of these start overlapping. So it's okay that you're seeing schizophrenia in this case, but make sure that you're understanding that this case is pointing us towards a woman with depression, and they are not giving us the diagnostic features of schizophrenia. So we have to, move our differential towards depression with psychosis.
So in the case of schizophrenia, it would be antipsychotics, not SSRIs, plus CBT. And in question, it would mention that it's been going on for a while. It would be a bunch of things. So they would focus more on hallucinations, more on their affect, more on other features of psychosis. And then they would talk about, they have a lot of other things as well. It would be very clear. So yes, you would give them antipsychotics, not SSRIs. And they would also give you a certain duration of symptoms.
Yes. And then one more thing with schizophrenia, while we're on the topic, they're gonna really emphasize on the three big things of schizophrenia, which is the negative symptoms, the positive symptoms, and the cognitive symptoms.
Yep.
So they're gonna tell you oh, this patient has thought blocking, and this patient has this, and they have flight of words, and they have hallucinations. You're gonna be, once you reach the end of the scenario, you're gonna say, oh, okay, they're specifically talking about these positive symptoms, these negative symptoms. Okay, let's start thinking about schizophrenia now.
Does that make sense, guys? I have a chat.
All clear.
Okay.
Yes. Okay, great. Next
Amazing.
question.
Okay. So a medical student who finished their neuro block last year has been visiting various doctors over the course of the last 10 months. The student is concerned he has Huntington's disease after learning about it in the block and finding out how terminal it is. The student has gone from clinic to clinic requesting genetic testing and imaging of his brain. Test after test has come back normal. What does the patient most likely have? A, somatic symptom disorder, B, illness, anxiety, C, conversion disorder, D, malingering, E, Huntington's disease. Okay, so we're getting a lot. Everybody's saying B, illness, anxiety.
Yay.
Good job, guys. Nice.
Yeah, okay. This is illness anxiety disorder. Do we need any further explanation? Does anyone not get why it's illness anxiety disorder? I think it's clear. By the way, I think I have
It's clear. Okay.
just this. This is my notes from last year. Somatic symptom disorder, illness anxiety disorder. They're two things that are easy to mix up. The way I found it pretty easy to differentiate them is that somatic symptom disorder, the patient is actually going to have symptoms. The patient's actually going to have a headache. The patient's actually going to have stomach aches. The patient's going to have, there's going to be something in somatic symptom disorder. Even if all the tests come back negative, the patient will have symptoms. In illness anxiety disorder, there's nothing, no symptoms or anything. The patient is just worried they're going to develop something. That's it.
You guys seem to be good with this. If you guys have any questions, do let us know. All right, so moving on to the next question then. All right, can I read it?
Yeah.
Okay. Eman is a 30-year-old woman who was brought to the emergency room by her neighbors 30 minutes after they found her unconscious in her yard. They report that Eman has been spending more time at home alone since she recently lost her job, on arrival. She is unable to provide a history. Her pulse is 76 per minute, respiratory rate is 13 per minute, and blood pressure is 114/72. Examination shows significant weakness of the left upper and lower extremities. She's able to stand on her toes. Her gait is unsteady. Deep tendon reflexes are 3+ and symmetric. Basically, they're fine. And a CT scan of the head shows no abnormalities. Which of the following is a most likely diagnosis? A, conversion disorder, B, factitious disorder, C, malingering, D, somatic symptom disorder, E, acute stress disorder, or F, acute hemorrhagic stroke. What do you guys think? So Rayan is saying I'm torn between A and B, but I'll go with B.
Okay, we're getting some A's.
Okay.
More answers. All right.
Okay, so Rayan, tell us why A or why B?
Oh, I got one. Oh. Well, Yara, can you message, what's your name on the thing?
Eman Chaudhri.
Can you message Eman Chaudhri? Because I don't have my chat open, so I can't see your answers. So if you could message her, then we can see it on that one.
Okay.
Yeah, okay, perfect.
Okay.
Okay, so we have
B, they pretend they have the symptoms for caring.
okay. Shall we begin the explanation?
She lost her job. Okay. Sure. Okay. So a bunch of you said A, and a bunch of you also said B, factitious disorder. Sorry, that's for the previous question. Sorry. Okay. Most of you said A for this. We got a D and we have 2 Bs. Sorry, 1 B. So let's see the answer. So it's A, conversion disorder. Okay. And do you want to explain why?
Okay. So basically what's happening in this scenario is that Iman is actually having these issues, right? She is actually having significant weakness of her left upper and lower extremities. And she is actually, these are all real things that are happening in her. But there is no like organic or biological cause for them. They are happening due to a psychiatric thing. What is the triggering factor for this is the loss of her job. Iman lost her job, and for that reason, she maybe subconsciously feels the need that she doesn't need to, use her arms and legs anymore. So what's happening here is that she is converting these negative emotions that she has towards the loss of her job to actual symptoms. And the characteristic thing of conversion disorder is that when you go and you start doing tests on the patient, everything is going to, her reflexes are normal, they're symmetrical, her CT is normal, there's nothing wrong. She's able to stand on her toes. There's nothing wrong with her, but she actually has these things. So the reason it's not factitious disorder is because there is a trigger for this. The trigger for this conversion disorder was Iman losing her job. Now, what helps me always remember conversion disorder is the story that Dr. Ali told while explaining this lecture about the woman who caught her husband cheating on her and then went blind for a little bit. Like that is something that actually happened. So there's usually a major triggering factor in conversion disorder, and then actual symptoms that are not backed up by any like clinical testing. That's what's going on here. Is that clear? Oh, I got them mixed up.
Yeah, it's fine.
That's fine. That's what we're here for.
Good you get it messed up now and not on the exam. Clear. Amazing.
Yay.
Yay, nice. Okay. Cool.
How
How
would
would
B
B present? So
present?
basically, factitious disorders, the symptoms are intentional, okay? And they have like a motivation for it. It's usually unconscious. So they're not going to be doing it because there was actual acute stressor in their life, and then all of a sudden, like psychologically, that affected them so much that their symptoms presented somatically, aka like in the rest of their body. This patient will like consciously create physical or psychological symptoms in order to assume a sick role. They don't have an acute stressor, but they will kind of present with symptoms factitiously, like fakely, basically. Okay, so that you have two types: imposed on yourself or imposed on another. So factitious disorder that you do to yourself. So for example, like they've had a history of like multiple hospital admissions. They're willing to even undergo like invasive procedures, etc. But there's usually like a motivational aspect to doing all of this. That's factitious disorder. Okay. When you impose it on another, it's typically done via like child abuse, unfortunately. So you basically, if you guys know the story of that girl who was in a wheelchair, even though she was able to walk, she found out, what was her name?
I don't remember.
I don't remember either. But that's basically factitious disorder imposed on another. Like the mother was giving her medications in order to not make her walk and everything, and telling people, oh, look, I have a disabled daughter and everything. They were getting benefits because of it. And then in reality, the daughter could walk. That is factitious disorder.
Yeah, Gypsy Rose.
Gypsy Rose, thank you.
So in factitious disorder, they're just lying. I mean, like in a blunt way, yes.
Yeah.
But don't say that to a patient.
People like, you're lying.
No, don't tell them they're lying.
It's a lot more subconscious than that. Like sometimes they will be so convinced that they have a problem because that's like the life they're living for themselves. It's such an unconscious motivation of why they're doing it. It's for so many reasons. It's not just like, oh, I'm lying because I just want attention. That could be that can be a motivation, wanting attention, sure. But again, it doesn't mean that the patient is lying. Sometimes it can just get to the point where they don't realize they're lying. Do you get what I mean? Run.
Got it.
Thanks.
Perfect.
Nice. All clear.
Yay. Also, sometimes they take / spread the infection for factitious disorder. I think, yeah, especially if it's imposed on another, they will. They're not necessarily an infection, not always an infection, but it can be. But they're doing something. Great explanation, Ibrahim. Next question. Oh, here we go. So conversion disorder, which is happening here, is just the presence of neurologic symptoms, like which we had in this in Eman here, but the absence of any neurological diagnosis. That's.
If you guys remember, just a really quick example of this so you don't forget it. For those of you who have seen the show Never Have I Ever, about the Indian American girl, this is not a spoiler. In the very first episode, she's in a wheelchair because she couldn't walk after her father died. Her father dying was an acute stressor. She couldn't walk for a while. That's conversion disorder. It affected her psychologically to the point where it presented physically or somatically. Okay? So that's your example.
Next question.
Yeah. Ooh.
Oh my God, I almost just showed the answer. Okay. Is my turn to read?
Sure.
A 32-year-old man who comes to the emergency department because of abdominal pain, a runny nose, and chills for 6 hours. He has also had diarrhea and difficulty sleeping. He appears irritable. His temperature is 37.1, pulse is 110 per minute, and blood pressure is 140/90. Examination shows cool, damp skin with piloerection. The pupils are 7 millimeters in diameter and equal in size. Cardiopulmonary exam shows no abnormalities. The abdomen is tender to palpation, and the bowel sounds are hyperactive. God, people are already answering. Deep tendon reflexes are 3+ bilaterally. Sorry. Withdrawal from which of the following symptoms is most likely to cause the patient's substances is most likely to cause the patient's symptoms. Now you guys can answer it. I'm not gonna read the options.
Okay, A, alcohol, B, methamphetamine, C, gamma butyric acid, D, barbiturates, E, cannabis, F, encyclidine, G, heroin. Okay, so diarrhea, difficulty sleeping, runny nose,
Hyperactive bowel,
damp skin, piloerection,
dilated pupils. Right? Dilated. Yeah, dilated. You're only gonna get 4 options in your final, by the way.
Yeah.
This is just the amboss effect.
Come on, guys.
You know, we're
Get it wrong. It's okay.
Yeah.
Okay, some are saying B, some are saying G. What else?
All right.
Okay. Another G.
Heroin.
Heroin. Okay.
Oh, did we spell heroin wrong?
No. Okay, so majority of you guys are saying G.
Should I show the answer?
Yep, which is correct. Okay. So this is not typically the way you would present if you are coming off of a stimulant such as methamphetamine. If you see dilated pupils, diarrhea, etc., that's usually due to withdrawal from heroin. Okay. So it's an opioid withdrawal, manifests with flu-like symptoms, so like rhinorrhea, chills. So this patient had a runny nose and chills for 6 hours. Sometimes it can look like they're having a cold. And fun fact, for pregnant mothers who are addicted to heroin, when their children are born, they can be very irritable and they can also have flu-like symptoms. And that is a very telling sign that this could be heroin withdrawal in a baby or opioid withdrawal in a baby. Okay, that might be a question. I'm not sure if it's going to come for you, but it definitely does come in the future, and either in step 1 or in your clerkship or whatever it is.
I think you guys take in neuro how to treat it. Did someone want to quickly say it? I don't know if you guys took it. Tell me if you did take it. If you did take it, answer. How do you guys treat a heroin withdrawal? Or an opioid withdrawal?
Okay, so Dania flumazenil.
Yeah, honestly, that's enough. If you can
Good
get the
enough.
flu part, you'll get it in
Yeah.
MCQ.
You guys can remember withdrawal causes flu-like symptoms. Flumazenil. I
Oh.
don't know if that's going to work.
I'm
but
learning now too. I think buprenorphine is also correct.
yeah, can be one of them.
Yeah,
For-
buprenorphine,
Naloxone.
naloxone, methadone. Got to chat. I think she's right, actually.
Oh, stop. Yeah, that's for benzos.
So correction.
Sorry.
Flumazenil
Oh my God, forget
is
about
for forget the mnemonic. Guys, forget the mnemonic right now.
Guys, I'm sorry, we've been fasting all day, okay?
Methadone and buprenorphine for heroin or opioid withdrawal. Flumazenil for benzo withdrawal.
Okay. Flumazenil, benzodiazepine. Okay.
Yeah, they both have Z's.
Opioid naloxone.
Both have O's. You guys will
I'm
figure
so
something out. Anyways, we're moving on.
I'm so
Whose turn is it to read?
Okay.
Wait, is everyone all clear with that question? Why it's heroin withdrawal? Yeah, okay, good. Whose turn is it to read?
Mine.
Okay.
Guys, genuinely very sorry for any confusion that we might have caused, okay? Feel free to call us out. Okay. So, a 46-year-old woman is brought to the emergency department 30 minutes after a bicycle accident during which she fell on her head and right shoulder. On arrival, she is awake and alert. Medical history includes type 2 diabetes and panic attacks. On examination, there is a hematoma or bleeding in her left temple, and her right shoulder joint appears dislocated. Neurologic exam is insignificant. The patient receives intravenous midazolam and fentanyl as procedural sedation for closed shoulder reduction. Following the procedure, the patient remains sedated for a prolonged time, and the physician decides to reverse sedation pharmacologically. After administration of naloxone and flumazenil, the patient develops tonic-clonic seizures lasting for 1 minute. Her pulse is 100 per minute, respiratory rate is 24 per minute, and blood pressure is 145/90. So those are all slightly high. Pulse oximetry on room air shows an oxygen saturation of 98%, normal. The patient appears drowsy and diaphoretic, she's sweating. Examination shows a tremor in both hands. Which of the following is the most likely cause of this patient's seizure? A, hypoglycemia, B, benzo withdrawal, C, alcohol withdrawal, D, fentanyl overdose, or E, subdural hematoma. What do you guys think? Okay, so one is saying C. What else? Okay. Why are you guys, a lot of you guys are going for C. So one of you or any of you, just tell me why you think it's C.
Why is this patient having alcohol withdrawal?
I'm not saying you're wrong. I just
Is
wanna
it
know-
because I put a space between C and alcohol? Is that why you guys think that's the right answer? This is the psych session. I'm tricking you guys. No, I'm kidding. But why do you guys think it's alcohol withdrawal? It's okay, we don't bite. We just made a mistake. Like literally 3 minutes ago. By the way, not all the questions are this long. We just started off with the longer ones while you all have...
Seizures are a sign of alcohol withdrawal, and she didn't consume alcohol for a while. Okay, but we didn't mention alcohol in here.
There is no mention of alcohol.
There's no mention of alcohol, so why are you guys so adamant that it's alcohol withdrawal?
It's
Sorry, that's
not a court case. Court case.
But okay.
Also,
yeah. Okay, so
alcohol
here's-
withdrawal is not the only thing that can cause seizures.
A lot of things can cause seizures, unfortunately. The hematoma, alcohol withdrawal,
Other
benzo
drug withdrawal.
Usually alcohol withdrawal presents after hospitalization. Sure, that's true. Okay, I'm sensing that the main type of withdrawal that you guys learned about is alcohol withdrawal. And so I don't blame you guys for thinking it's that.
It's important.
It definitely is. But in a question about alcohol withdrawal, you're going to have a very obvious history of alcoholism in a patient, because alcohol withdrawal is not normal in patients who have like a glass of wine a day, or like even like 2 beers a day or something.
Should we show them the answer?
Okay, so we're going to show you the answer. So someone said B. Good.
Yay!
So
It's
it is
benzo
benzo withdrawal. So in benzodiazepine withdrawal, and your clue, go back, is this question?
Yeah, it's this question.
Okay. So the point over here is medical history also includes panic attacks. And a way that you treat panic attacks is through benzodiazepine. So that means that this patient is probably taking benzodiazepines normally. And so when they are taken off of benzos and they're given flumazenil, because that's what you give to reverse benzos, flumazenil, benzodiazepines, right? You can develop a seizure. Okay.
So I have the explanation here so we can read it through it together.
There.
So I'm just going to read this to you guys so we don't make a mistake again. Flumazenil is a benzodiazepine antagonist that can cause acute withdrawal, and it can precipitate seizures in patients who are using benzos chronically, and like this patient is taking for her panic attacks. This patient has a history of panic attacks, which means that she's probably taking benzodiazepines, which means that if we gave her flumazenil, they're likely going to trigger benzo withdrawal in her. And the symptoms of benzo withdrawal are going to be things like everything you see in this case. So it's going to be things like tonic-clonic seizures, drowsy. They're going to be very drowsy. They're going to be very sweaty. They're going to have a tremor. So just be careful when you are reading a psych question. I think a common strategy we all adopt in like first and second year is that we skip to the end of the question and then look at what they're asking. Don't do that. Read the full case now. You're reaching a stage in your medical career where every single part of the question is a clue to the answer.
Mm-hmm. Or something they're trying to throw you off. So it's like, which keywords will stand out to you correctly, basically. You're going to make a few mistakes before you actually get it, but it is important to, you can read the very last line and then go back and read the full vignette, but do, like Ibrahim said, always read the full vignette, okay?
I think we're all clear as why this is benzo withdrawal.
Do you guys have any questions?
Flumazenil. Sorry.
Guys, benzos, flumazenil, okay?
Okay, it's clear now. Great.
Mm.
I'm going to the next question. It's my turn to read.
These are so long.
It's fine. I don't know why I said 25-year-old woman is brought to the emergency room by her boyfriend. We forgot to write that. She cut her forearms with a knife. She has had multiple visits She had multiple visits to the emergency department in the past few months for self-inflicted wounds. She claims that her boyfriend is the worst person in the world. She and her boyfriend have broken up 20 times in the past 6 months. She says she's going to cut herself, not because she wants to kill herself, but because she feels alone and empty and wants her boyfriend to take care of her. Her boyfriend claims that she is prone to outbursts of physical aggression as well as mood swings. He says that these mood swings last a few hours and vary from states of exuberance and self-confidence to states of self-doubt and melancholy. On examination, the patient appears well-dressed and calm. She has normal speech, thought processes, and thought content. Which of the following is the most likely diagnosis?
A, bipolar I, B, narcissistic personality, C, histrionic personality, D, cyclothymic disorder, E, antisocial, F, dependent personality, G, bipolar II, H, borderline personality. So every single person said H or borderline, and you guys are correct.
Correct, yay.
Borderline.
So wait, just quickly for the person who said bipolar, this is not bipolar because in bipolar disorder, we're probably going to have a case that is more, it's going to be a longer case, and we're also going to have more indications of mania and depression. Here we don't really see a lot of depression, and the mania lasts for 4 to 7 days.
Or
Also, in borderline personality disorder, this is like the most classic presentation of borderline that you're going to get in a question stem. Okay, it's going to be self-inflicted wounds. It's going to be fighting with their boyfriend. They feel alone. They feel empty. We're the worst person in the world. Like, it's going to be very intense, like black and white thinking.
Yeah.
Okay. So
very push-pull. If
yeah.
you see that in a question, it's safe to say BPD until there's something that really throws you off that you might be like, okay, maybe it's not BPD.
Yes.
Yeah. So the key word is self-harm.
Yes, self-harm and female. This is what Dr. Ali says.
Yeah.
It's maybe not super politically correct, but that
it's more
is
common that way.
Yeah, it is more common this way. And honestly, especially the self-harm thing, at least for your stage, pretty much majority of the question stems that you get about self-harm are going to be borderline right now.
Most of the time,
Yeah.
at this stage. But obviously, you know,
there's
in real
other
life, you will
causes.
know that there are other reasons that people self-harm, unfortunately.
So I think we all got this. You guys answered before I even showed you the options. So I'm moving on.
Great. There you go. Concrete thinking. All good, all bad, push, pull, black, white, everything we mentioned. Self-doubt, identity crisis, very rocky interpersonal relationships. There's a big fear of abandonment. So it's like, I hate you. I never want to see you again. And then never mind. I love you. I need you.
Yeah, they broke up 20 times. I think like it literally says this in the question. Yeah, they broke up 20 times.
In the past 6 months.
Yeah. So it's
so tiring.
Like that.
Yeah.
Next question. Oh my God. God.
When we were making these, we did not realize how many of them were that long, but it's okay. So, a 28-year-old woman comes to the physician because of a 1-year history of chronic abdominal pain that developed after starting a job at a law firm. She also has abdominal bloating and constipation that started 2 weeks ago. She's had no pain with defecation or change in stool form or appearance. She's upset because she has seen 2 other physicians who performed tests but were unable to make a diagnosis. The patient is currently on sick leave but would like to return to work as soon as possible. She often worries about having a gastric ulcer that may perforate and insists on getting an endoscopy. She does not smoke or drink alcohol. She reports that she is under significant pressure from her managers because of frequent performance evaluations. She has a history of childhood asthma. She takes multivitamins and glucosamine daily to prevent arthritis. Her vital signs are within normal limits. The abdomen is mildly distended and slightly tender. The remainder of the examination, including neurologic examination, shows no abnormalities. Lab studies are within reference range. Fecal occult blood tests and urea are negative. Which of the following is the most likely explanation for this patient's symptoms? A, adjustment disorder. B, illness anxiety. C, malingering. D, irritable bowel syndrome. E, conversion disorder. F, somatic symptom. Or G, factitious. So
we're getting,
everybody is saying F, somatic symptom disorder. So
I was getting ready to sum up the case for you guys too. Oh my God, I have a PBL tomorrow. Just remembered. So any other guesses? Anyone unsure? You guys are right. Anyone unsure anyone not sure why this is somatic symptoms?
In your chat. Oh, okay.
This is
for the
what am I saying? everyone's clear as to why this is somatic symptom disorder, correct? So this patient just had real, do not worry, perfect. Okay.
Okay.
This patient had just had clear, they had actual abdominal pain. There was nothing really wrong with them. It's somatic symptom disorder. The key idea here is that they started a new job at a law firm, which makes you very stressed. Think about it. You guys are probably getting stomach aches and stuff while you're preparing for your neurofinal because you're also in a peak of high stress. There you go. Oh.
Can I read it?
Okay.
Okay. A 38-year-old woman comes to the physician for a 6-week history of sleeping difficulties because she thinks that someone is watching her through security cameras. Her anxiety started 6 weeks ago when a security camera was installed outside her house by the police. Ever since, she has felt that she is being monitored by security cameras throughout the city. She avoids going outside whenever possible and refuses to take the subway. Whenever she needs to leave the house, she wears large hats or hooded sweaters so that she cannot be recognized by the cameras. As soon as she arrived at her office or at home, she feels safer. She was recently promoted to the team manager of a small advertising agency. She takes no medications, and on mental status examination, she's alert, oriented, and shows a normal range of affect. Urine toxicology screening is negative, and the patient's symptoms are best described by which of the following? A, delirium, B, agoraphobia, C, delusions, D, derealization, E, disorganized thoughts, F, avolition, or G, hallucinations. So you guys are saying, so we all have somatic symptom disorder. I think you all have IBS because you're stressed.
No,
No.
That's a big diagnosis to be making.
It's true.
So just like to summarize quickly what's going on in this case, because it's a long one. This woman thinks that she's being watched by the cameras that were installed outside of her house by the police. And she doesn't want them to watch her.
She feels safe when she's at home or in her office. So some of you are saying C, delusions. Some are saying B, agoraphobia. Can anybody define agoraphobia? For those who are,
It's not arachnophobia. I made this mistake during the progress test. They're different things. Fear of social places.
Fear of social spaces,
exactly. Yeah. Spaces, sorry. Yeah, exactly. So this woman is not afraid of social spaces because she feels fine at her office and she doesn't mind going out. She just thinks that she's having delusions of persecution. That's the answer.
So a lot of you did say C, so good job. It's not delirium. Delirium is very different. We can describe it just in a second, but typically you will see delirium more often in older patients.
Yeah, and delirium, I believe, is also not based in reality. It's a fixed, it's like a fixed belief that's not based in reality. So I think delusions, I might be completely wrong, so we're verifying right now, but I believe delusions are something that can happen, right? So this is, you could be being watched by the police on cameras, but delirium could be something like there are aliens speaking to me, or there are, I'm being contacted by.
Okay, so delirium is disorganized thinking, illusions. You can have hallucinations, cognitive deficits,
Exactly.
Emotional lability, or basically very rocky emotionally, agitation, combativeness, and this is typically more often in older patients. It can happen especially in hospitalized patients, more specifically in older patients with a hip fracture. Whereas delusions are fixed beliefs derived from erroneous inference. So you don't necessarily have other cognitive, issues. You're not necessarily irritable, but you can just be like, no, I know that
this is happening to me right now.
Yeah.
Like, I know that the police is watching me through the cameras right now. And okay, yeah, that could be happening, but there's no rational reason why the police would be installing the cameras to watch her through her house.
Okay, so delusions can happen due to multiple things. Delirium, typically, there will be a cause. It can be a metabolic cause. It can be due to infection, such as UTI. It can be, again, due to prolonged hospitalization, problems in the brain, such as like a stroke, a hemorrhage, a tumor, certain drugs, but those don't cause delusions. Okay, so that's going to be like another way that you differentiate the two. Okay, here's the chat, 1 second.
Two new messages.
Also in delusions, your personality is intact.
Yes.
Yes. One can
And-
continue their day and daily activities and practice job. Exactly.
And they
Yes,
told
good
us,
job.
that she's a team manager. She's a team manager. She's going to work. She feels fine at work. Like, she just has this delusion, but she's carrying on with her life.
Mhm. Let me open the chat.
So the Pokemon.
What went on?
Wait, someone's asking about the Pokemon. What about the Pokemon?
So they're like, so the Pokemon is a delusion.
Pokemon is a hallucination.
It's not like a fixed belief that like I know there are Pokemons out on the street
She saw
at
one.
all times. She just saw one. She's like, I saw a Pokemon.
I saw
on
a
the street.
Pokemon. I just saw like a Pikachu running across the street.
It's not an erroneous belief that is continuous. Does that make sense?
Can you make your thing full screen? So
I'm
that we can make the chat?
trying to. How do you do that?
You do this.
Oh. Oh, there you go.
Perfect.
Okay.
All right. Nice.
Nice.
We're moving on.
Okay.
So this woman is having a delusion.
Great.
16-year-old girl comes to the physician because she's worried about gaining weight. She reports that at least twice a week, she eats excessive amounts of food, but feels ashamed about losing control soon after. She's very active in her high school's tennis team and goes running daily to lose weight. She has a history of cutting her forearms with a metal tab from a soda can. Her last menstrual period was 3 weeks ago. She's 165 centimeters and weighs 57 kilograms. Her BMI is 21.5 or 21 kilograms. Whoa. Physical examination shows enlarged, firm, parotid glands bilaterally, and there are erosions of the enamel on the lingual surfaces of the teeth. Which of the following is the most likely diagnosis?
Okay, so some of you are saying C. Okay, a lot of you are saying C. So good. So your hints here are basically,
No, you guys tell us the hints.
yeah,
What are the
Okay.
hints here?
E because of loss of control, binge eating disorder. Okay,
Someone said teeth. Yes.
good. BMI.
Yeah.
What about the BMI, Dania? BMI above 18.
Mhm.
Okay. Shame, compensatory behaviors.
It's
Yes,
normal.
it's normal.
Yeah, exactly. Parotid. Yes.
Good.
That's a really important thing.
Yeah.
Okay. So just for people who may not know, this is bulimia nervosa. So this patient is eating and then compensating by throwing up. And the reason we know that she's compensating by throwing up is because of her enlarged parotid glands and because of the erosion of the enamel on her teeth. These are happening because, you know, she's retching, she's throwing up, and then the acid from her vomit is eroding the teeth.
Mhm. Also, another thing, by the way, now I know in your exam, they're going to bring it in a lot more obvious manner like this, but sometimes they can be like, oh yeah, this, there's like a young girl or young woman, she's very obsessed with exercising and keeping like a good weight. She's here for a regular checkup. Her potassium is low. Your potassium is usually low in bulimia. So that could be another hint, okay? If they're not mentioning like the very obvious traits, such as like parotid enlargement, erosions of the enamel, lingual surfaces. So low potassium can be another hint, okay? Obviously, you're going to be like putting it in the context of the vignette. So it's like a young woman who is very obsessed with like keeping a certain weight, etc. She eats regularly, but she does, you know, like she's mindful of it, etc. She has low potassium. That could be a sign that she's throwing up, okay? So does that make sense to you guys?
I'm gonna answer that one too fast. Guys, we're getting into the shorter questions
Yeah.
now. These, by the way, this is a style of psych question that you're gonna get in your final.
Most likely.
Like, we wanted to start. We wanted to
Guys, wait.
slow down. I didn't want to show it. We wanted to start with the longer ones to show you how to approach like a psych question, but the way Dr. Ali writes questions is this. Like,
Yeah.
literally, he's gonna give you maybe 1-2 lines.
Majority of them are going to be quite short. Okay, so schizophrenia is considered disease targeting. So some of you, one of you said C, cognition, one said B, thinking, two said B, thinking,
So
and then
between thinking and cognition.
yeah, one said E, concentration. Yeah. So what do you guys think? Okay, more are saying C, cognition.
I find these style of questions to be more difficult than the
Yeah,
longer
honestly.
ones, because there's
Throws you
nothing to
off.
like, there's nothing to think about. It's either know or you don't.
Kinda, yeah.
Should I show them
So
the
a
answer?
lot of you guys are saying C.
I'm
The
gonna.
answer is
The answer is B.
thinking. So just think thought blocking.
All right. So schizophrenia does affect cognition, but it's more an disease of thinking. A patient with schizophrenia is not able to think properly, pretty much. They have thought blocking, they have flight of ideas, they have, it's basically mostly completely affecting their ability to think, their ability to move on to it. Okay, I didn't put a slide, but just this is one of those things that you kind of just memorize and
Just remember this.
you know it.
Schizophrenia targets thinking.
Are we good?
Sorry, guys.
They're gonna start answering the next question. I'm scared. I showed it.
Okay.
I'm moving on.
Okay, so a woman just gave birth and started feeling slight depressive symptoms within the first week of her delivery with no effect on social activity. Which of the following is the most correct diagnosis? Okay. Whoa.
Slow down. No, I'm kidding.
No, good job, guys. So a lot of you guys are saying B, postpartum blues. Does anybody else have any other guess or idea? You're not, it's okay if you get it wrong. Okay, so a lot of you guys are saying B. Majority of you guys already did.
So yeah, this is a normal thing that happens when you give birth. I'm gonna make the same stupid joke and say I'm speaking from experience. No. Yeah, it's within the first week. She's feeling blue. It's not affecting her social activity. They're not giving you CG cap signs. She's just having normal reaction to giving birth while her hormones leveled out. All right. Postpartum blues.
Okay. Good question.
This is just the slide of postpartum. So postpartum blues, again, are mild symptoms of depression. Postpartum blues usually last like 2-3 weeks. Like they're not a very long lasting thing. They don't affect their life. It's fine. Here's another question. I'm going to read it. They're going to answer before I finish. Patient suffering from anorexia nervosa started treatment. While undergoing treatment, the resident treating her infused her with too many nutrients too quickly in an attempt to speed up her recovery. Which of the following is likely a dangerous complication of this?
Okay, good job, guys.
I think they know the answer.
Yeah. I have a feeling you guys have seen this somewhere, but yes, it's C, electrolyte imbalance. Okay. To be very, very careful about this. Why? Why is electrolyte imbalance so scary? Give me 2 things.
Can I answer?
No, you're not a second year.
I can't even name 2 things.
Okay, good. So Rashadan said arrhythmia. Okay, as could cause paralysis, low potassium.
Okay.
Now, what's the problem with low potassium? What can happen? Okay.
Die.
Yeah, you can die because you can get an arrhythmia, you can get heart block, you can literally predispose the patient to seizures as well. So that's why I was looking basically for arrhythmia seizures. Okay, but there's a bunch of things that can happen, and you guys are all right. Good job.
Now, for the schizophrenia question, doesn't cognition make the most sense? Like a person's mental state is affected, his thinking, his personality, everything. So
can I be real with you? Yeah,
it does, but this is one of those things where it is thinking. Again, okay, also cognition is cognition is a very grand topic. Cognitive abilities contain a lot of things like day-to-day activities, just making lists of making lists. And patients with schizophrenia still have the ability to do various cognitive things, okay? Even though they're not, they don't come off as normal to other people, they still have the ability to make cognitive decisions. Isn't thinking a part of cognition? If we get into this, we're never going to end this PAL session. Thinking is a part of cognition. What is the true brain? What is the true self? I'm going to go crazy. It's all to what extent? No,
the theory of knowledge is really.
I'm burning up.
Okay, no. Okay, but for this electrolyte imbalance, okay, but that is a good question, Noor. Yeah.
Wait, I want to make sure she got it. Noor, do you understand why it's thinking? Or are you okay with it being thinking? You don't have to fully understand it, but are you okay with it being thinking?
You don't have to be okay with it, but you just accept it for now until you're done neuro.
You don't have to be okay with it. I think I understand.
We think we understand too, but anytime, and we're sorry we can't give you more than that right now. Really, really, we wish. But yeah, next question.
Next question.
Okay.
Which of the following features
easy
correctly defines the features of bipolar disorder 2? I said features twice.
Okay, bipolar 2. Okay, so some are saying C, some are saying D. Now, it's okay. These are hopefully the two that you would mess up together and not another one of them. So, one said B, hypomania and mania. Okay, so,
Do I show it? See, sorry again. Okay,
okay.
ready? I did the drum roll after.
Yeah.
It's hypomania and depression. So mania and depression is for bipolar 1. A lot of people, including me, are confused. They're like, oh, why is bipolar 1 mania and depression, bipolar 2 hypomania and depression? The way I like to think about it is the first thing that they discovered, I don't know if this is historically accurate whatsoever, but the first thing they discovered was probably bipolar 1, where they saw the mania, which was up here, and the depression, which is down here. So they're like, okay, yeah, this is bipolar 1. And then eventually, as I saw more psychiatric patients, they were probably like, okay, wait, there are people who are not going mania like here, they're going hypomania like here. And they're like, okay, we'll call that bipolar 2. That's why bipolar 2 is hypomania and depression.
Mhm.
Does that make sense?
Another way you can think of it, even though like I feel like it is all clear, is like mania is bipolar 1, and manic people think they're like number 1 in the world. They're on top of the world. So bipolar 1. Hypomania, they're just like getting their job done, they're functioning normally, then they go into depression and they come out of depression and they function normally, etc.
Wait, there's a picture here.
There you go.
There you go. All clear? All clear. I think we got it.
Mhm.
I'm moving on.
What is the length of a brief psychotic episode?
I didn't even read it. They already answered.
Okay, so some of you guys, a lot of you are saying A.
Did you guys? Okay.
They're all saying A.
Yeah, okay. It is. It's a brief
job.
psychotic episode. It's less than 1 month. This is a question that we got.
Purely recall.
That's a recall question. Just know a brief psychotic episode is less than 1 month. Here it is. It's a differential diagnosis for
1 month or less.
yeah. And if they having hallucinations or having delusions, all of those for 1 month or less, then yeah.
All right.
Someone already said this in the chat earlier. What are the most common hallucinations in schizophrenia?
You guys know this. Okay, so one said C. Oh. One said A. I mean, they all occur.
Yeah, these all can have olfactory, I don't know. But these all can happen. Okay, then yes, these all can happen in persecutory is not a hallucination. Persecutory is a delusion. But all of these can happen in schizophrenia.
No, wait, D. Most common is D. So, but majority of you are saying D, auditory, which is correct.
Which is true. This is it. Auditory is typical in schizophrenia and more common.
Yeah. It's not the only one, it's just more common. Okay. Olfactory, gustatory, so like taste and smell are a lot less common, but it does happen. Okay. So it kind of goes from like auditory, visual, tactile. So like you feel like you're touching certain things are touching you. Olfactory, then gustatory. Okay. Visual is more common in delirium. So this is kind of how you can like differentiate it, I guess. So people with dementia are a lot more paranoid, okay, generally. People with schizophrenia more often have auditory hallucinations. People who are delirious more often have visual hallucinations, okay? That does not mean that they don't experience the other things. Those are just the most common in those respective things. Do you guys understand that? Say yes, please. It's okay if you don't. We can re-explain anything that you guys like. We'll re-explain it 40 times if you need. Great, perfect. Thank you.
What is the most common fear in social anxiety disorder? Again, this isn't a recall question.
So majority of people are saying B. We've got one A. A is agoraphobia. So we talked about agoraphobia.
It's not the fear of spiders. It's the fear of social spaces. Yeah.
Okay, so majority are saying B.
So yeah, negative evaluation. So people who have social anxiety, what really fuels them is that they don't want other people to perceive them in a negative manner. They don't want other people to say like, oh, this person's weird, this person, you know, oh, why are they walking like this, or why are they presenting like this? You know, they just have a fear of negative evaluation. He also put it in a huge block of text in the middle of the slide and then said, this is an exam question. So I think it's important. I don't know. I'm not sure.
Yeah, agoraphobia is very commonly mistaken with social anxiety. This is also in boards and beyond, but social anxiety is, oh, what will people think of me? I'm scared of what people will think. I'm scared they're not going to like me. Agoraphobia is like, I'm scared I'm not going to get home. Like, I don't really want to be around people who are not, you know, like, I don't want to be in like a space where I'm worried that I can't escape it, you know? Social anxiety is not about like, oh, I'm scared I'm not going to be able to get out of it. It's more like, oh, what will people think? I don't want to perform. What do people think I'm bad, etc., etc. Okay.
Agoraphobia can be related to panic attacks. Yeah.
Yes.
It's not the only cause of panic attacks. A lot of things can trigger panic attacks, but like it is, yeah.
I would go more with anxiety attacks because it's a known cause of your attack. Panic attacks are more often due to you don't know why they're happening. Okay. Yeah, if that makes sense. All clear?
Yes.
All clear.
Should I read this one?
Is this the last one?
No. There's
Okay.
there's
A few more. Okay.
So a 21-year-old man comes to the physician because of nervousness and difficulty sleeping over the past 2 weeks. 3 months ago, he started a new team project at his job. He says that he has trouble falling asleep at night because he thinks about this project. He insists on checking the work of his teammates and spends several hours each week making elaborate lists and schedules. He refuses to let others take on more tasks because he thinks that he only can complete them satisfactorily. The project deadline has already been postponed once. He says, my teammates never understand how important it is to do things the right way. Ever since high school, he has used the majority of his time to plan out assignments and does not have time to regularly participate in social activities. Which of the following is the most likely diagnosis?
Okay, so some of you are saying A and some of you are saying B. So let's go back really quickly. Okay. He insists on checking, refuses to let others take on more tasks because he thinks that he can complete them satisfactorily. Ever since high school, he's used the majority of his time to plan assignments and does not have time to regularly participate in social activities. Now,
wait, I'm gonna go back to the options.
Yeah.
I want you guys to, yeah, you're thinking. Let your, we'll let
let
you
your
think.
juices flow.
Oh,
Okay, so some of you are saying A, obsessive compulsive. Some are saying B, obsessive compulsive personality.
perfect.
Now,
This is why
before,
we brought this question.
yeah, before we go on to show you guys the answer, tell me the difference between OCD and OCPD. There is a specific word that you use to describe OCD and a specific word. Yes.
Yeah.
Okay, so Ghaid said egosyntonic and ego-dystonic. So which one? And Rushdan, good job, both of you. So, and Muhammad, okay. So OCPD is ego-syntonic and OCD is ego-dystonic.
Yes.
Ego-syntonic means they're okay with it. They want to do it. They like it. Ego-dystonic is like, I have no control. I hate my life. This is making me miserable. I don't want to be like this.
Yeah.
Okay.
So in people with OCD, like by the way, the answer to this question is OCPD. In a scenario where you have OCD, I don't think OCD, first of all, will typically present on something like this. OCD is going to be more repeated tasks. So something like opening and closing the door a bunch of times, or continuously repeatedly washing your hands, or counting something to a certain number. And they're going to mention specifically in an OCD case that the patient is almost frustrated with these thoughts. They don't like having these thoughts. It's ego-dystonic. Here, he thinks he's doing the right thing. And actually, I have a slide here. This is the difference. Ego-dystonic, they don't like the thoughts. OCPD, ego-syntonics, they like it. All right. He also mentioned to us that most doctors have OCPD traits.
Yeah.
Because
no, we look at them.
Yeah, like our attention to detail, we're perfectionists, we're very rigid, we want to do this and that, and we're devoted to our work. So those are OCPD traits. We don't think what we're doing is wrong. So we get the difference between these two things. Yep.
Great.
Nice. Oh,
Okay.
guys.
You didn't see that. You didn't see that, okay? Anyway, a 45-year-old male surgeon is highly functioning at work. His family and his coworkers complain that he's arrogant and always talks about how great he is. You're gonna meet a lot of people like this in the hospital. Okay? There have been complaints about him exploiting others for his own selfish needs and being envious of others' success. The surgeon complained to the doctor that he is too important to have waited in the waiting room for as long as he did. The surgeon most likely has NPD, HPD, PPD, paranoid schizophrenia, or grandiose delusions.
Okay, you guys saw the answer. No, but you would have gotten this. This is
Yeah.
narcissistic personality disorder and a pretty obvious scenario of it. This surgeon thinks he's better than everyone else. He thinks that he's worth more than everyone else. He's talking about how great he is. He says, he even said, like, why am I waiting in the waiting room with these other people? Like, I'm too important to be here. So here's just like a table from Amboss, rest in peace, to describing. Now, you don't need to know all the diagnostic, like the DSM-5 things for narcissistic personality disorder, but here are some of the like typical things that you're going to see in a case for narcissistic personality disorder. You know, they're going to think they're self-important. They need admiration from others. Think they're the best. They lack empathy. They're envious of other people. And they're pretty snobbish. So that's OCPD. I think this is your question.
Sure, I can read it. Okay.
Wait, we're good?
Are we good here with that?
Are we good?
Don't show the answer again,
I'm
please.
trying. Are you good? Are we okay? We're good. Okay.
Great. Okay.
Is this
Yes, all good.
okay.
Nice. Okay. So a 23-year-old man comes to the emergency department with palpitations, sweating, and shortness of breath that began 10 minutes ago. He said, "Please help me. I don't want to die." He has experienced several similar episodes over the past 2 months, which occurred with warning in situations including with warning or without warning. I'm going to go with without warning in situations including open spaces and crowds, and resolve gradually after 10 to 20 minutes. He has been staying home as much as possible out of fear of triggering another episode. He has no history of serious illness and takes no medications. He drinks 2 bottles of beer daily. He appears anxious and has a flushed face. His pulse is 104 per minute, respirations are 20 per minute, and blood pressure is 135/82. The cardiopulmonary exam shows no abnormalities, and an ECG shows sinus tachycardia. Which of the following is the most appropriate initial action by the physician?
Wait, before I show you guys the option, what do you guys think this person's having?
Okay, so one said agoraphobia, one said panic disorder. I knew one of you was going to say agoraphobia. And one said alcohol withdrawal, more saying panic attack. Panic with agoraphobia. Okay. Okay, so we'll show you the options.
Now answer the question.
Okay. So A, do you want to perform a cardiac stress test? B, measure plasma metanephrine levels. C, administer oral venlafaxine. D, oral alprazolam. Or E, oral propranolol. So a bunch of you are saying A.
Oh.
Interesting.
Oh,
no, I like
no, by
this.
the way,
like this.
No, they're right.
They're not.
In the way that Dr. Ali taught them, they're right.
Oh.
I just realized. Yeah. You have to, it's okay.
Wait.
You know what? Assuming for the question, we ruled out organic cause.
Okay.
Now we ruled out organic cause.
Okay, so over here they did an ECG, completely normal.
But wait, actually they did do an ECG.
Yeah, that's what I'm saying. ECG is normal. It's just sinus tachycardia, which everybody, when you exercise, you get sinus tachycardia, okay? Cardiopulmonary exam shows no abnormalities. And he's 23 and he doesn't have a drug history, if he's being honest. He's telling you he has 2 beers daily. He's 23.
Okay, wait, no, but the way, okay, listen, you guys, the way you learned is right, but an ECG was done, so it's not an MI. We ruled out the organic cause already in the question stem. Now what do we do?
Let's say it's not A. So B, pleasure.
Plasma metanephrine levels, oral venlafaxine, oral alprazolam, oral propranolol.
Okay. What do you guys think? So firstly, a lot of you guys are saying that he has a panic attack or panic disorder. Some of you said alcohol withdrawal. Rustan, why did you go with alcohol withdrawal? I'm not saying necessarily you're wrong, but I just want to know your reasoning.
Also, answer the question.
Yeah, please.
Daily beer.
Okay.
Yeah, potentially.
Okay, so a good number of you are saying
Saying
D.
D.
One said venlafaxine, C. So should I go ahead and show the
Yeah,
answer?
go ahead.
Okay, so the answer is D, oral alprazolam. So this patient is having panic attacks. So I'm sorry over here, this should say without warning in situations including open spaces and crowds, okay? So your hint over here is palpitation, sweating, shortness of breath that began 10 minutes ago. Several similar episodes. He's a young man with no other comorbidities or problems. And he says, please help me, I don't want to die. Feeling the sense of dread or that you're about to die is very commonly associated with panic disorder or panic attacks. Especially panic attacks are not the same as anxiety attacks. Anxiety, you know the trigger. Panic attacks, you don't know the trigger. So over here, the trigger is not known. Again, without warning. I'm going to fix that before we send this to you guys, okay? Without warning. He doesn't take any medications. So like Ibrahim said, and done ECG, cardiopulmonary exam. So like Ibrahim said, organic causes and other causes are ruled out. Okay, so now that when you know it's a panic attack or panic disorder, the first way that you treat it is with benzodiazepines. So in this case, alprazolam. Okay.
Yes, and then also cardiac stress tests. Isn't that when you exercise and they check?
Yeah.
Okay, so if we are suspecting an MI, we're definitely not going to get the patient on the treadmill to see how their heart performs under stress. So just general knowledge for you guys for when you start CVP next year. Cardiac stress test is not, if we're suspecting an MI, that's definitely not something that we're going to do.
You do other stress tests on the bed chemically. You don't make them run on a treadmill. If they're having like angina, yes. But again, it's a young man, no other organic causes. But yes, you do want to rule out organic causes or like heart issues first. And then you want to go into your psychiatric diagnoses, because the way you treat psychiatric diagnoses can affect the rest of your body because of the medications. They're very strong.
And then doctor said if the patient's around 50, do the cardiac.
100%.
Yeah, for sure.
For anybody who's above 50.
I guess the way you want to approach it is they come in, do an ECG, make sure it's not an MI, and then we can start treating it and then start looking for other causes. We want to see what's going on. But the answer to this is give him a benzo.
Yes.
Put a benzo in his pocket.
And so just to go over the other things. So for example, what drugs for when? So a lot of people you might know, for example, when they're feeling anxious, they take propranolol, which is a beta blocker, a non-selective beta blocker. Now, in this case, you might think, okay, why not just give him a beta blocker? He'll calm down. Well, it's more often for performance-based social anxiety. You'll usually take it beforehand or when you start to feel a little anxious. A lot of people take it right before an exam. I don't recommend you do this if you have not done it before. Talk to your doctor first. But yes, propranolol or a beta blocker for performance-based social anxiety. Buspirone, which is another antidepressant, antipsychotic. It's a long-term treatment for anxiety. Thiamine is for Wernicke encephalopathy, which can happen with alcoholism. And I think it was Rashdan who mentioned, he takes alcohol and everything. Again, he's a young guy, so it's very unlikely that a guy at 23, unless he's drinking
an excessive amount,
bottles of spirits a day, he's not going to have severe alcoholism to the point where he has Wernicke encephalopathy. If the patient's age were higher, then yes, we can definitely think about that. Okay. Also, the presentation is a lot more indifferent. They're going to have gait instability. They're going to have cognitive dysfunction, a lot of other problems. Okay. And then alprazolam is a benzo, and it's used in acute settings for panic attacks, like for this patient. So Abdurrahman is asking, but wouldn't it also hint to agoraphobia since he's scared of open space and stays at home a lot? Well, I understand why you're asking that, and I wanted to touch upon this. But the reason that it's not agoraphobia is because his fear is not, oh my God, I'm not going to be able to get home. That's not his primary fear. That's not his primary reason of staying put. His primary reason of staying put is if that episode happens again, I don't want to be in an open space when it happens. That's all.
Also, the episodes just, happen to occur in open spaces and crowds. That doesn't mean that he's necessarily afraid of open spaces and crowds.
Does that make sense, guys? Any other questions?
So put a benzo in their pocket. Clear.
Okay.
This is the second to last question. A woman was out at a bar drinking when she suddenly felt drowsy and lost consciousness. Upon regaining consciousness, a toxicology report showed that a drug normally used to treat narcolepsy was slipped into her drink. Which of the following drugs was used?
You guys are so fast.
Yeah, mashallah. Yeah, we're getting some answers.
Okay. Okay, so we've got some people saying D, Xyrem. What else?
You better not be Googling the drugs right now.
Yeah.
I mean, we won't know, but don't. For your own good. I want one more answer and then I'll show the answer. Okay, great. Two more. Yeah, so it's Xyrem. So not common, but like it's something important for you to know. Xyrem is known as the date rape drug, and it acts so fast that typically when given for things like narcolepsy, they tell you to take Xyrem while you're already in bed because it is going to knock you out almost immediately. These other drugs here are not going to do that.
Yeah. So nortriptyline is just tricyclic, I think, antidepressant. Yeah. Fluoxetine is an SSRI. Modafinil is I forgot, honestly.
Is it an SNRI? You guys know this better than I do. We do.
Methylphenidate is
also modafinil. We're verifying. Do you know how hard it is without Amboss?
Okay.
Is it an SSRI?
It's a stimulant. Modafinil is a stimulant, so a stimulant will not make you pass out.
Modafinil does also treat narcolepsy, yes, but it's not going to act as fast to knock a patient out. Yeah.
Also, we're asking about like losing consciousness. So yeah, Xyrem, you might see it in another way in the question. They might say sodium oxybate or gamma hydroxybutyric acid. Okay.
Xyrem is the brand name of the drug.
Alrighty.
Okay, guys, this next question, this is our last question. I'm not going to show it to you so you don't answer. This is our last question. In my opinion, it's a little bit advanced for you guys, and I just wanted to include it for fun because I think it's actually a really sad question, but it's a really cool question. But if you want to leave, like that's it for our review. This is just the last bonus like question. I'm going to read it. So a 5-year-old boy is brought to the emergency department by his mother because of a sudden loss of consciousness. He has asthma and he has been hospitalized multiple times. His mother has type 2 diabetes mellitus. He is somnolent and diaphoretic. Serum studies show a glucose concentration of 22 milligrams per deciliter and a potassium concentration of 2.4. A dextrose infusion is administered, after which the glucose concentration normalizes and his symptoms improve. He is admitted to the hospital for further observation. Overnight, he has another episode of decreased consciousness. Serum studies taken during the episode show a glucose concentration of 19 and an insulin concentration of 108, which is way above the normal levels, and a C-peptide concentration of 0.3, which is below the normal levels. Which of the following is the most likely diagnosis?
A, malingering. B, glucanoma. Okay, so
wait, let them answer.
No, I'm not going to tell you guys the answer yet. Also, Ibrahim will take charge of this question because we're more excited about it. But a lot of you are saying, some of you are saying G, some of you are saying D.
G because I like the letter. I mean,
because grade starts with G.
If it works, it works. G. Wow. Guys. You guys are getting it. Are you guys just getting it because this is a psychiatry pal session? And so you know the answer is going to be psychiatry related. But you guys are correct. This is actually a child abuse case. And I got this from Amboss. It is a sad question.
Yeah.
I guess I spoiled it. So what's actually happening here is that this mother is injecting her son with insulin, and causing, exactly, this is Munchausen by proxy.
Good job.
The
Yeah.
mother is injecting her child with insulin and making him have hypoglycemic episodes and passing out and then taking him to the hospital. And it's the kind of the same idea here as like the Gypsy Rose thing that we were talking about earlier.
Exactly.
And the reason that you know that she's injecting him with insulin is because the child's insulin concentration is super high, but the C-peptide, which is cleaved normally from the normal insulin made in the body, is low, which means that this is exogenous insulin. This is insulin coming from an external source. So this mother admitted the child into the hospital, and then in the night while the child was sleeping in the hospital, went and injected her son with insulin so that he would enter a hypoglycemic state again. So this is factitious disorder imposed on another. Yes, this is a very, very, very sad case.
Yeah.
But it happens.
A lot, actually. One of the first things that you have to rule out when you're dealing with pediatric patients is child abuse. And a lot of the time, the child abuse can be very not obvious in the way it happens. And this is one way you might just think like, oh, what's happened to this child? But you always have to consider that this is being done by the parent, because a lot of things are messed up. Yeah, moms can do this to their kids, unfortunately. That's to parents in general. I'm not gonna
with that
specify, but
yeah,
this is important. So very last thing, and then this is basically just the diagnostic criteria by symptom duration. So a lot of you guys asked, for example, about schizophrenia, about major depressive disorder, etc. So if you look over here at the bottom, this is literally straight out of first aid for step 1, okay? 2022, but this has not changed. So over here you have the duration, so 0 weeks to years, etc. And over here you can see, for example, in sleep disorders, narcolepsy is greater than 3 months. Childhood disorders are over here. We're not going to go into this. But anxiety disorders, for example, panic is greater than a month. Less than a month is acute stress disorder. If it lasts for a longer time, then it's post-traumatic stress disorder. And typically with post-traumatic, again, anytime you see the duration, cool, okay. But you always have to see it in its specific clinical context. What else did the patient experience in their past? What might be making them feel this way? Was there a specific trigger? Was there not a trigger, etc.? So this will help you kind of classify where you want to place your diagnosis, and then you look at the duration and you can tell, okay? So it goes hand in hand.
I think the most important one for you guys to know is the psychotic disorders.
Yep.
So just know that brief psychotic is under 1 month. Schizophreniform is pretty much all the schizophrenia features, but between 1 to 6 months.
Yeah.
You're not going to call it schizophrenia until it's more than 6 months of the same symptoms. Okay. This is like, I think, the most important one for you guys to remember. And then here are the mood disorders. This is just a good table to kind of look at and commit to memory. And thank you. Also,
we did it.
We did it.
We did
Factitious
it,
disorders. Factitious disorders is not just saying he's sick all the time. No, factitious disorders, especially imposed on another, are usually abuse cases. It can be a caretaker on an elderly patient. It could be a mother on a child, the father on a child. It isn't just saying like, oh, they're sick. You could actually be doing something. It's very, very sad. We hope this was helpful.
Allah yuwaffiqkum. You guys are going to do great in neuro. You guys did great in the session. I hope you guys learned something, even just one thing. That's the most important thing. If you guys have any questions at all, genuinely, please do not hesitate at all. Email, text, anything. Don't feel shy. We love to help out, okay?
One word of advice. I want you guys to please spread this around to your batch. Psychiatry is not something that is optional that you can skip in the exam.
Yeah.
It will be probably a majority of your exam. They have tested your neuron. It was a majority of our exam.
Okay.
They tested, not a majority. It's a huge chunk of your exam. Okay. They tested your neuroanatomy knowledge and they tested a lot of these things in your midterm. There's a lot of room for psychiatry. So please do not think it's one of those things that you can just read the night before and be fine. A lot of people in my batch struggled with psychiatry because of this like notion that, okay, it's just something that, it's psychiatry. It's not that important. Mm-hmm. It's very important. And it is going to be very prominent in your exam, whether that be in SAQs, MCQs, anything. So please.
Also, last thing is like, if you guys are, in a crunch for time or something, from experience and from other people's experience, and a way that you will actually remember and it will help you, Boards and Beyond Psychiatry. The videos are not long. They give you everything you need to know. And if you watch those and then quickly just like skim through Dr. Ali's slides, if you're in a hurry, perfect. And it's plenty. And also first aid for psychiatry. It's not long. It's a great way to quickly review certain concepts. I 1000 billion% really recommend that you guys like look at that if you guys are also going to watch Boards and Beyond. And again, if you're in a crunch for time, it's a perfect way to study psychiatry. Okay, it has everything that we touched upon today, has a little bit more maybe that you don't even need to know, so you can skip over it, but it's all very organized there. But 100% I would recommend Boards and Beyond. Okay, doesn't take much time and it gives you everything you need.
What questions do you guys recommend? What sources?
With the death of Ambos, UWorld PDF that you can find in our OneDrive.
I think
no, it's great, I swear.
Listen, it's a little advanced. UWorld, I feel like UWorld could be a little advanced for psychiatry, just because the second half of this lecture is the style of psych questions you're going to get on your final right now.
And I'll tell you very honestly, this goes for neuro, for psych in neuro, and this goes for every block you will encounter from now on in medical school and then after. UWorld tells you everything you need to know and more. Your concepts will be incredibly clear after. Don't be intimidated by the length of the questions, and they're not there to trick you. Okay, definitely use it. You don't have to do all the questions. That's overkill, honestly. But you can tell yourself, like, I'm going to do like 30 and call it a day. Because when you do one question, it gives you the answer to 5.
True.
Okay, so when you start, you'll know what I mean if you've never used UWorld before. But definitely check out like the PDF. But if when's your guys' exam?
Thursday? No, Sunday.
Sunday.
No, it's Sunday.
Yeah, so I would still recommend, like, you guys do have a few days. If you've never used it, I would suggest taking a look at it. If you don't like it, forget about it. Okay.
Should we use wait, hold on. Let me stop can we stop the recording just before we go into like